So how I manage the patient with ITP who has failed initial therapy with corticosteroids and has subsequently failed therapy with rituximab. The first thing to do is to make sure that they really have failed therapy with rituximab and that you have given them an adequate trial of time after rituximab therapy. Remember that it can take up to 56 days before patients show an initial response. And so don't call them a system failure, a rituximab failure, until after about 2 or 3 months after rituximab. Now, after they actually have really failed, your treatment options are pretty broad, but at this point, I like to use a thrombopoietin receptor agonist, either romipilstim, avatrombopeg, or L-trombopeg, the latter two being oral therapy. Some patients go on and use a further immunosuppressive agent, such as mycophenolate, in which case the thrombopoietin receptor agonists are used as a bridge for the immunosuppression to kick in. Splenectomy, which used to be used right after or sometimes before rituximab, has really moved very distal to third-line therapy at this point in time. Now, again, after patients have failed initial therapy with corticosteroids and rituximab, our treatment options are thrombopoietin receptor agonist plus or minus immunosuppression. Much less and much further along, we would put splenectomy as third-line therapy. In the era of COVID, the American Society of Hematology has recommended against the routine use of corticosteroids and rituximab for therapy of ITP, and they recommend the use of immunoglobulin, IVIG, and thrombopoietin receptor agonists to avoid therapy with immunosuppressing agents. Now, if your patient is already on an immunosuppression regimen and is doing well, we do not recommend that that agent be stopped, but continue with careful monitoring.